potassium's through the roof. What are we going to do with this little jiu-jitsu? This is going to be an admission for sure. Do we have any beds on the floor?
They're at 23 patients, but I think with the weather getting nicer, they might be starting to admit out on the front patio. We're going to have to deal with that potassium first though, Dr. Nellum.
All right. We'll use the typical Hyperkalemia Cocktail. I just need to go talk to Allison in the lab about some pandemic stuff for a few minutes. I will order it when I get back.
A little longer than a few minutes later.
See, you've got lunch.
Well, I can't sort all these problems out on an empty stomach now.
All right, well, while you've been gone, I've actually been doing some work. I started an IV on this fella and connected him to the cardiac monitor in case he pops into VTAC. Check out those peaked T waves, wide QRS, and long PR interval.
Oh, wow. I'll go write those orders now.
2 hours later.
Well, Alicia, I finally got those orders done.
Wow, Dr. Nellum, I think that's the quickest that I have ever seen you get orders done. However, with these nursing shortages lately, we've been having a really hard time replacing sick calls. I think you better come with me to learn how to administer these meds. I've heard rumors that you might be working alone in the ED next week.
Why does this patient have to show up in my emerge at this hour? Now I have a problem I have to sort out. This patient doesn't look so good, Alicia. Are you sure they're alive?
I don't know. You're the doctor. Anyways, first we'll go ahead and push the calcium. We stock both calcium gluconate and calcium chloride.
Both are acceptable in the management of hyperkalemia, so we'll just use whatever's ordered.
We're going to push it over 2 to 5 minutes as per the Ottawa manual.
It's been a long time since I've been to med school. I can't actually remember why we give calcium. I don't see how that's going to lower the potassium level.
Good question, Dr. Nellum. It doesn't actually lower the serum potassium level, but it does reduce the risk of cardiac arrhythmias, such as VTAC.
All right, that's pretty important. I guess that's why we always give it first.
All right, so now that we've given the calcium, I'm going to push the dextrose. We're going to give the dextrose before we give the insulin in case I lose this IV site. The dextrose is going to counteract the hypoglycemia effect that the insulin may cause.
Push the insulin. I see a lot of nurses mix the insulin in a mini bag.
I know that sounds kind of scary to push insulin, but the insulin can actually bind to the mini bag and tubing. And because of this, in cases of hyperkalemia, the Ottawa manual recommends that this dose be given IV direct so that the patient receives the full intended dose.
Well, I guess that makes sense.
All right, now that I've given all of these medications, I'll start the Ventolin neb.
Giving insulin and Ventolin? Why did I order those? Doesn't it seem silly?
No, Dr. Nellum. These medications both work to shift the potassium from the vascular space back into the cells. After the serum potassium is reduced to safe levels, we can then focus on lowering the total body potassium. Total potassium is eliminated by renal excretion, GI elimination, or dialysis. So after we get done here, you might want to consider ordering some K-Exolate or IV furosemide after we've acutely managed this patient's hyperkalemia.
What about sodium bicarb?
This is a good adjunct therapy for metabolic acidosis, if their blood gases warrant it.
We can dilute the sodium bicarb in D5W or normal saline and infuse over 4 to 8 hours.
Wow, that has been very helpful, Alicia. Maybe I should have gone into nursing instead.
We're always hiring.